So now we are going to go to see the very last part of the meeting. This is just some cases that we selected, and hopefully you will like, and we can wake up a little bit. This is a long day. I had the pleasure to share this session with Andan Castrati, and the expert panelists here are Lorenzo Hernando and Paula Antuña. Okay. And so I think we should move on and see the first case. David?
So thank you very much for being here for the last session. So we have been talking about all the amazing things that we can do with the drug-coated balloons. I am also a believer of this technology, but I would like to present this case for create some controversy and for show you that all that glitter is not gold. So I present you the case. It's a 17-year-old male with a cardiovascular risk factor. He's a diabetic patient with hypertension, dyslipidemia. He's a former smoker. And he had a chronic kidney disease, an end-stage chronic kidney disease with a baseline creatinine around 3.5. So the patient had a long history of coronary artery disease. He started in 2010 with a non-STEMI, and he underwent a PCI in the distal right coronary artery with implantation of drug-eluting stent. The patient was asymptomatic during 12 years, but in 2022 the patient presented with another non-STEMI, and the proximal right coronary artery was treated with another drug-eluting stent. And the patient was again admitted in our hospital for another non-STEMI 2 months ago. So here I show you the angiogram. So here you are the left anatomy. You can see a diffuse coronary disease in the LAD and the circumflex with no coronary significant stenosis. And you may anticipate that there is some problems in the right coronary artery, as you can see, filling the distal vessel by collaterals. So I show you the culprit vessel. Here you have the stent implanted in 2022, that is quite good. But in the stent implanted 13 years ago, there was a flow limiting in stent restenosis. So we usually study this kind of patients with intracoronary imaging. So in this case we perform OCT, and here I show you the details. So this is the distal part of the stent that is quite good with a good expansion, but at the level of the bifurcation we can identify from stent restenosis with an heterogeneous tissue, and also, and it is very important, we identify a mechanical problem of the stent. There was a severe underexpansion here in the distal part of the right coronary artery. So according to these findings, this is our procedural strategy. We start with a 6-frame guiding catheter, 2 wires, one for protect the side branch, and we try to optimize the expansion of the stent. We use a non-compliant balloon 3.0, and we inflate it at higher pressure. And after that, we decided to treat this in stent restenosis with a DCB. So we are including patients in the scoring registry. So in this case, we use a sirolimus drug-coated balloon. So we use it in this case. We use a drug-coated balloon of sirolimus 3.0, and this is the result. This is a very good result. We can say a stent-like result. And the patient was discharged on aspirin and ticagrelor. But 2 months later, the patient started with chest pain and ST segment elevation in inferior leads. So the patient was transferred to our center for a primary PCI, and here are the result of the previous of the previous angioplasty 2 months later. So there was again a severe stent restenosis in the distal stent in the right coronary artery. So at this point we were concerned about the renal function. So we did not intracoronary imaging, and we treated directly. So we start with a non-compliant balloon 3.0 at high atmosphere, and we decided in this case to treat it with a drug-eluting stent. We changed the drug and we use a drug-eluting stent, a everolimus drug-eluting stent 3.0 with a very good result. So this is an interesting point to discuss some issues with the panelists and also with our guest expert. So how often do you see an early recurrent in stent restenosis in your daily practice? Is something that you see commonly or not? In those patients, do you prefer again to treat it with a drug-coated balloon, or you change your strategy and you use a drug-eluting stent? And in some patient or in some profile of patient, does the drug selection matter? So maybe there is not the same drug for all the patient, and we have to select the proper technology for one patient or the others. So we are open for discussion.
Okay, so the reason we selected this special case, perhaps again playing the devil's advocate, is that when you go to all these drug-coated balloon meetings, everybody's telling you that, well, after using a drug-eluting balloon for treating a de novo or in stent restenosis patient, if there is nothing acute, there is no way that you will have a late stent thrombosis or a vessel closure. In this very case, it was clear that we use OCT to understand the mechanism of stent restenosis with some under-expansion. That was corrected during the procedure, and eventually we obtained a beautiful angiographic result for stent restenosis with this novel drug-coated balloon. And then the patient presented with STEMI, so fulfilling the definition arc of stent restenosis. So this is very rare. I don't know if other experts in the field have seen that, but this is again a case where late after the treatment of stent restenosis, the presentation is a STEMI and acute vessel closure. I mean, because the only way to present that is that we haven't seen that, and most experts say that this never happened.
Did you repeat the OCT before doing the DCB? Did you repeat the OCT before doing the DCB?
Yeah. So this is the OCT after pridilation?
Yes.
No.
I mean,
Yeah.
that's more important. If I have only one run of OCT, I would do after, because the initial strategy, we always say OCT tells what is the strategy, but the strategy is the same, inflate a balloon. What the difference strategy?
But I think, are you sure that it was restenosis and not stent thrombosis of the area? Because it was acute, which is not typical for restenosis to present with acute STEMI.
Yeah, you're right.
Yeah. And how was the antiplatelet therapy at the time?
It was aspirin and ticagrelor.
Ticagrelor.
Simon.
Did you image it the second time? When they came back, did you image it?
Sorry, imagine?
Did you do OCT on the second?
No.
So, okay. So not at the end of the first and not at the beginning of the second.
Yeah.
So we all have to guess the cause, don't we?
What is the balloon was? What is the name?
This is one of brown. We are using in the score registry. So it's a new generation.
I believe
Antonio, I was so excited, as you are, when I see this patient and we miss having OCT. But I like that you are so excited because of this.
I think for the moment being, we should not talk about paclitaxel or sirolimus. We should especially name the type of balloon, because we don't have a class effect. There are some sirolimus that may work, some sirolimus that may not work, so we still need to be more specific.
Sure. More questions? Simon.
So it's either a mechanical problem with the stent that you've just wrecked 2 months earlier, or it's a thrombotic thing, isn't it? Did it behave like thrombus the second time? Or did it behave
Yeah, it could
like...
be. It could be thrombus.
Did it behave like thrombus, or did it behave like in-stent restenosis the second time round? Because they feel different with your balloons, don't they?
So you mean that the second case is more thrombus than in-stent restenosis?
Yeah. What did it feel? How did it behave when you were...
Yeah, we have not imaging for that, but our suspicion is that it was more thrombus than restenosis.
It's also fundamental to repeat the imaging after predilatation. When we were implanting Absorb, we, in order to save time, we only did imaging after post-dilating at 24 atmosphere, and then we did imaging. And despite this aggressive pre-imaging approach, 22% of the time we had to do something more. Go higher pressure, take a bigger balloon. So imaging, you have to do it at the end until you are happy.
I mean, I fully agree. I mean, the issue was an acute setting, so there was an emergency procedure. The patient has severe renal failure, but yes, we should have performosity.
At the end, you already resolved the problem. You already opened the vessel, so you can take your time. You already have,
Okay, your point is well taken.
Was the patient taking the pills properly?
Say that again?
Taking the pill, I mean the medication, the Cagrelor.
Yeah, he was on.
He was on drugs. I mean, he didn't forget to take the pills.
No. He didn't forget her medication. He said several times that he was taking the pills properly.
So this isn't a question you'll be pleased to know, it's more of an anecdote. We had a young chap that came in, had a primary angioplasty many years ago, had a 2.5 stent in the distal right. He then came back about 5 years later as a primary angioplasty. Somebody looked at his distal right coronary artery and decided that a 2.5 stent in a 4mm vessel was probably too small, blew it up to 4, put in a DCB. He was fined for 2 years, and then he came back again as a primary angioplasty due to the same area. That time round, what they noticed on imaging was the stent that they post-dilated aggressively before was now in 2 completely separate bits from the aggressive post-dilatation from the second time. So these things happen, don't they?
When did you do the second? How much time is between the second and now? Because the first time you
2 months.
2 months
Yeah.
to have the stent thrombosis.
Yeah.
And now are 2 months already?
No, it's 1 month.
1 month.
Yeah.
Let's wait.
Okay, so you just present this.
Yeah. Yeah. Thank you very much. Thank you.
Thank you.
David. The second case is presented by Pilar Jimenez Cuevedo.
So thank you very much. We are almost closing this session. And thank you, Fernando, for inviting me for this interesting meeting. This is the title, Intracoronary imaging is always a wise idea, as we just discussed in the previous case. This case is about a young woman, 68 years old, probably contrast agent allergy is not proved. She has dyslipidemia, type 2 diabetes, hypertension, and is currently a current smoker. The current presentation of this lady was non-STEMI. She had, and on the EKG, we can see the ST depression in lateral leads, and the laboratory test show a creatinine clearance of 40 millimeters per minute. So I was impressed of the history of this patient. This is a timeline. In less than 2 years, this patient underwent 4 angioplasty and 1 CABG. Let's start in January 2021. The patient had a non-STEMI, and the angiogram showed 3 vessel disease. A severe stenosis in the proximal circumflex that was treated with 2 drug-eluting stent implantation, 2.75 and 2.5. The lesions in the LAD were intermediate, diffuse intermediate, and the lesion of RCA were also intermediate. So in a second procedure, the patient was underwent a pressure wire that was positive. So after 7 months, the patient underwent a CABG with a lima to the LAD and a radial artery to the RCA. So 4 months later, the patient has an inferior STEMI that was treated in another hospital, and the angiogram showed restenosis, the first restenosis in the circumflex that was treated with 3.0 stent. So the patient has 2 layers in this circumflex. The graft were occluded, the lima and the radial graft, and then the LAD and the RCA was treated with a drug-eluting stent. 9 months later, the patient again came with a non-STEMI. This is the second restenosis in the circumflex at the same level, at the proximal segment, that was treated with sirolimus DBS. The stent on LAD and right coronary artery were patent. 3 months later, the patient was admitted again to our hospital with the third restenosis at the same level. No imaging was performed before, and then the stent on LAD and the right were patent. So this is the angiogram. So you can see the LAD with the stent, they are good. This is the third restenosis of the proximal circumflex artery, and the right with the very good result of the stent. So we perform IBUS because we need to know what is going on. This is not normal, the third restenosis in the same level. You can see this is the distal left circumflex, and then we are after the predilatation. We can see this is the proximal part with some neointimal tissue and under expansion and calcium outside the stent. This is the left main. So in detail, we see the in-stent neointimal area at the proximal circumflex was 8.5, whereas the in-stent area at the distal was 9.7. So we had a percentage of under expansion of 81%. And if we look at the diameters, in the proximal 2.7 and in the distal circ 3.1. So we treated this restenosis with predilate with non-compliant balloons 3.0. And then following predilatation, we saw that there is a still under expansion on the proximal level. So we decided to use IVL. Remember that the first stent implanted at this position was 2.75. The second layer, 3.0. We use a lithotripsy 3.5 to treat this segment. After the lithotripsy, because we had some watermelon movement, we use a cutting balloon to treat, 3.5 to treat the proximal segment of the circumflex. And So this is the IBUS for after the cutting balloon. As you can see, no, this is previous. Okay, this is the final IBUS. This is the distal circumflex. You can see, well, the very nice result. This is a well-opposed stent, huge in stent area, and in the proximal part, which was the problematic part, we increased the area. You can see a small amount of residual neointima hyperplasia, but we achieve more lumen area, as you can see here in detail. Previously we had 8.5 in stent area, and now in this proximal part we have 11.5, and the distal part was almost the same. So after that, we treated this part with the drakelutin balloon, paclitaxel 3.5, 15, and this is the final result. We already have 6-month follow-up that was clinically uneventful. And these are my conclusions. First, restenosis may be due to mechanical or patient characteristic, for example, diabetes or chronic kidney disease, but recurrent restenosis is a mechanical problem, mostly under expansion. So intracoronary imaging is mandatory for following the first restenosis, and drakelutin stent is a good therapeutic option to avoid the 3-layer stent as has been shown in this case. Thank you very much.
Thank you, Peter. So, any question from
Lorenzo?
Congratulations, because I will do the same. This example of the use of the
I didn't.
Congratulations. It's a good result.
Yeah.
Okay.
No, I have a question, but this is for Anand. I mean, Anand just published in your intervention a novel score to predict recurrent restenosis in patients with in-stent restenosis. And you know, the typical issues were there, but striking to me that was the presence of a circumflex coronary artery. So we all know that the ostium of the circumflex coronary artery is very challenging when you do a crossover in the left main, or where you fail to stent that part because you don't want to have a protruding stent. But apart from that, the circumflex coronary artery is quite challenging vessel for in-stent restenosis. Tell us your explanation for this finding, the circumflex, a predictor of recurrences.
I think that it has to do with the ostium most of the cases. For us, the ostium circumflex of the circumflex is the most challenging location for stenting. So we have seen it, and especially in patients who come with bifurcation lesion at the left main, and sometimes you don't get rid of this restenosis at the ostium of circumflex.
We have published this week on heart a paper showing that ostial circumflex restenosis. This was a MACE comparison with ostial LAD, that the circumflex location is worse than ostial location in LAD.
Even here, after the treatment, I had the impression that the ostium was not well dilated, and this will be the problem.
No, this was not the case. Yeah. The case was that we didn't treat the under-expansion from the beginning. So
it's also very difficult to treat it. It's even with OPN balloon, we don't have optimal results.
I mean, the other question, this is again for you. Sometimes we accept as an optimal result in the ostium of the circumflex because we don't want to have a protruding stent or jail the left main or whatever. So is this because we are accepting these suboptimal results and we don't treat this restenosis in other vessels, or it's just a specific reaction of this location?
And we have done. Earlier, we have done a lot of culotte stenting in left main, and I have changed in the last years to do or T stenting, mini crash, or DK crash for circumflex. I had the impression that it's better than culotte because you have more material, more stent material there, and more drug probably, but it's still challenging. I have one question about the bypass, because two grafts were occluded. Were they put in vessels with a good flow? What was the reason for it?
I really don't know.
Yeah.
I really don't know, because if you see the LAD after the stent, the distal part of the LAD was very good for the graft. I really don't know.
So Thomas.
Yeah, thanks for sharing this very difficult case. So clearly there was a mechanical problem in the circ because they implanted 2 small stents in the first operation. But this patient might have some kind of genetic problem, so that smooth muscle cells will proliferate because the grafts were occluded. At least I have sometimes encountered a patient that had gone through many PCIs, everything occludes, and then grafting, and you have occlusions in the ostial parts of the grafts because of the sutures. But my question is that, what do you do when the patient comes back the next time?
I hope this is not going to happen. I really don't know. I really don't know.
This is basically when I consider combining 2 different drug-body balloons, treat them.
Okay, Ricardo.
Pilar, did you check the coronaries just before surgery? Because it took 6 months from the index case to the surgery.
No, the thing was, because this patient has a pressure wire after the first dilatation, so...
My point is, maybe the circumflex was already diseased before surgery. So
no, I don't think so, because between the pressure wire and the surgery was 1 or 2 months.
I was going to reply to Tom's question about what do you do next time. So with people that keep coming back like this, if you get a good angiographic result and the ARVA shows that you haven't got a major problem still, we have a very small number of patients that we've triple treated them with sequent please. So we put 3 balloons in one after another to the same spot. And that certainly stopped some, but not all of them coming back again.
So you mean using 1 balloon, 1 minute, another one?
Three balloons.
3 doses, three balloons.
But the same drug, the same balloon,
Yeah.
3 doses.
Yeah.
Just to increase the dose of the drug.
And, well, just anecdotal experience, or?
Well, so we've done it in enough now to know that most of them haven't come back. 2, in fact, 1 did last week, 3 years after her previous. But
Okay. So thank you very much, Pilar. I'm not sure. We don't have the final case. Yes. Oh, sorry. Please come in. So Sergio López Tejero is presenting the final case.
Thank you for the invitation. It's my pleasure to be here representing our team in Salamanca. This is our case, which is titled DCB, when the answer maybe is in the simplicity. We will present 87 years old man with a good quality of life. He's a former smoker, hypertension, dyslipidemia, and digestive disorder. He was following up at outpatient clinic with angina in a CCS2 class with a poor response in medical treatment. The echocardiography showed preserved in the low percentage left ventricle ejection fraction with lateral hypokinesia, and the other chambers and valvular were well. So at this point we decide to ask and expect. As we can see here, it shows us a positive clinical response with angina and also dyspnea, moderate and reversible inferolateral ischemia, and mild loss in the ejection fraction. So we decide to order an angiogram. As we can see here, it has a CTO in a proximal circumflex artery. So we decide to treat it. We go in an anterograde approach, with step-up wire strategy, Cyan Blue, Infiltrac Plus, and Progress 200T. And at this point, we saw that we were in a subintimal place, but we saw that at the distal part of the vessel, we were in a true lumen. So, but we weren't able to re-entry even with those wires. So we decided to perform a simple PCI with a balloon of 3 millimeters, and the result wasn't very good. We increased the dissection, of course, and the flow wasn't pretty good. So at this point, we were thinking, and we realized that we could do a investment procedure. So we decided to do it with a drug-coated balloon, which is a Sequin Please Neo, and we treated the whole vessel, and the result at this point wasn't pretty good, with a TME flow 2 in some vessel and less in the other ones. So we weren't happy with this, but we decided to stop at this point. We got an appointment 60 days after the first procedure to the patient, and he told us that he was completely asymptomatic just 2 days before the procedure. And what was our surprise, that we saw that the dissection was completely healed, and the flow was the flow was almost perfect. So we wanted to see better what happened. So we performed a CT and OTC, and we saw that there were some other plaques in the distal part, but at the level of the proximal occlusion, we saw that there were some kind of dissection and spheroid dissection, but it was completely healed, and there is not 2 lumens, as we can see here. So this is the 3D image, and this was the images from the OTC. So just another few quickly case, because we think that maybe the investment procedure with DCB it's working. We think yes. And this is another patient with a complicity of the right coronary artery and also the LAD. We healed the right coronary artery, and we decide a retrograde approach after an anterograde approach of the LAD by septal branches. So after reaching the cap, the distal cap, we could perform a PCI, but we re-entry at the proximal part in very proximal in the LAD, so we didn't wanted to lose the diagonal. So we performed another investment procedure with a drug-coated balloon, and the result wasn't as good as we would like either. So we decided to took the same strategy as the other one, and of course it was better 60 years ago, but as you can see here, there is a dissection imaging. So in this situation, we decide to perform PCI with a stent, and the final result was pretty good within. So just to conclude, drug-coated balloon investment procedure could be an option in CTO as a destiny therapy, as we saw in the first case, or maybe presenting enhancement of anatomy. Thank you very much.
Okay, so any questions? The use of drug-coating balloons in occluded vessel. I think this is an emerging topic, especially when there is very diffuse disease distal to the culprit part. Lorenzo?
I have no experience in this case. review of the result, the final result.
Simon.
It's a good job Bruno's gone, because he hates people putting drug-coated balloons in the subintimal space, apparently. He says that you can get aneurysm formation. We've done what you've done. Yeah, it works really nicely. Sometimes, like you say, it just starts the procedure, sometimes it finishes the procedure.
Yeah, we have done 5 cases, I think. It's just anecdotal experience, but until we have done, it works.
Yeah, I think I don't know whether it's a Chinese or a Japanese paper where they've deliberately gone subintimal, just delivered a small DCB and brought them back, and quite often it's...
Yes, and there is also a paper from Valladolid, from Dr. Ignacio Amat, and it is comparing drug-coated balloon against the normal balloon, semi-compliant balloon. And the result, they said that they are almost the same, but in cases that you wanted to perform an stent in a second procedure, if you used the drug-coated balloon, it seems that it makes you easier for the stent in the second procedure.
It's a very forgiving thing to do, to stop when you've only used balloons rather than start putting any stents in that then cause a problem. And I think that's one of the many hidden benefits of doing lots of DCB angioplasty, is that you realise in all of your cases there are a lot more points in time where it's safe to just stop and either do it another day or change your plan altogether.
Yeah, for example, in the second cases, we just stopped because we didn't want to lose the diagonal, because it was a big vessel as well. So we decided to stop, and after the procedure, let's see how was everything and just decide.
Yeah, they're great cases.
Thank you.
Thomas?
Yeah, Franz Kleber collected a small series of CTOs, maybe 2016, and we also contributed with a few cases, and it was shown that if there was a symmetry flow, then the vessels were open in 93% of cases in control angiogram, so it seems to really work. And we especially use in cases of undergrade wiring, intraplaque wiring, high bleeding risk patients. But maybe I'm a little skeptical if you have to dissect the vessel, really bad to use DCB. In those cases, we usually combine DCB and DES with the dissected part.
I don't know.
Final word?
No, this is exactly what we do also. Just we cover with the drug-eluting stents the entry, and the rest, the periphery, we do with DCB.